Hello, viewers. We welcome you again to another episode of The Pew and the Pulpit, coming to you live from the Anglican Church of the Holy Spirit here in the Bronx, United States, New York, Bronx, New York, United States. The address is always 3840 Seaton Avenue, off the highway from 95. If you are driving down like you're going to Connecticut, 95 highway. Today with me in the studio is our own person, a doctor with a difference, a core Anglican. I always like to introduce him as a core Anglican. He's the son of a priest. His father was an archdeacon in this church, and he has dedicated part of his life to mission, and part of the mission is to educate us about our health. So today we have with me Dr. Some Onua. Doctor, you are welcome.
Thank you very much.
So Doctor, I know the last time we met we talked about prostate cancer and other topics that you have discussed in the past. They are helpful, but today I want you to throw light on this issue of BPH. When you hear BPH, what do you understand by that, sir?
Thank you very much, viewers. Welcome again. So today we're going to be talking about BPH, as he mentioned. So BPH, benign prostatic hypertrophy. So it's a disease of the prostate gland. And benign, once you hear benign, means there is no cancer. So benign means it's a growth, but it's not cancerous. Prostatic means it is the prostate. Hypertrophy means enlargement. So if you hear hyper, it means increased. Hypo means decrease. That's atrophy, that's reduction in size. So benign prostatic hypertrophy is one of the three main disease conditions that affect the prostate. Like I mentioned, the other ones are prostate cancer and prostatitis. So BPH, as an overview, it's a disease that also affects men with increasing age. Men below 50 years of age, there is a reduced risk if you're below 50. But as we grow older, the risk increases. It is said that below 50 years of age, about 15% of men will have this. By 70 years of age, about 40%. And by 80 years of age, about 80% of them already have BPH. So you see, majority of people above 75 years old have BPH, which is simply put an enlargement of the prostate gland. Like I mentioned in our previous episode, the prostate gland has a volume of about 20 to 50 cc's. And once you have it enlarged, usually we say above 50, but definitely if it's above 70 cc's, it's enlarged. And also if the dimensions are more than the usual 4 centimeter length, 3 centimeter width, and 2 centimeter in depth. Benign prostatic hypertrophy accounts for medical visits, about 1.7 million medical visits here in the US. And it also accounts for about 250,000 procedures, surgical procedures per year here in the US. So you can see it's a significant thing that it's happening in men with increasing age. The world over, also, BPH is more prominent in black population as well. And it could come with a whole lot of symptoms. Some of them we can notice, some we may not notice until it gets to the advanced stage of the disease.
Wow. What are the causes of this BPH?
Yes, so when we say causes, so it's good we say causes. Sometimes in medicine, it's more of risk factors. So some disease conditions, there isn't actually anything that will cause it. It's just that there are risk factors. For example, if you're male, there's a risk factor. If you're female, there's no risk. So you can't have BPH if you're female. So if you're male and you're above 50, then the risk of having BPH is there. We often joke and say, well, when our patients complain about BPH, we say, well, one thing is good. That tells me you're above 50 years of age. Because if you die before 50 years, you probably not have any problem with your prostate because it wouldn't grow big enough. So, yes, increasing age is a risk. Then also the other thing is increasing abdominal pressure. So we know that people who for some reason have problem with getting their urine out. So people who there is some obstruction or some restriction to urine flow could have a problem with their prostate, because what happens is that it starts getting enlarged at a very early point in their life. So when we say causes, so this will be some of the things that we see that could increase the risk. So it's more of increased risk than a cause of it. There are so many other things in terms of some minor research that people have done that they attribute as causes, but this doesn't rise up to the level of clinical significance for us to group them as causes. So for now, we just have increasing age in men. That's the main risk of BPH.
Wow, Doc. This is indeed, as we grow older in life, we face more risk. This is what I understand with all this health issue. A lot of diseases come with age. So, but nevertheless, age is a good thing. It's a blessing. But as we age, things in our body gets weaker. So, having said that, Doc, what are the symptoms?
Right, the symptoms of BPH. So the prostate gland itself, to take you back to the prostate gland itself is made of two main areas. So one is the epithelial area, or what we call the glandular part of the gland, and you have the muscular part, or the fibromuscular part of the gland. So the fibromuscular part of the gland, which is the muscle area of this gland, contributes about 70 to 80% of its volume. While the glandular part, or the epithelial part, which is the part that brings the secretion of the seminal fluid, this constitutes 20% of the gland. So majority of it is in the muscular part. That is what constitutes this volume of this gland, which I say the gland is 25 grams in weight. So for this, what now happens is, for you to have prostate hypertrophy, which is enlargement of the prostate, there is an enlargement of one or these two areas. So the muscle area increases in size, the glandular area increases in size, and you have benign prostatic hypertrophy. And when you have this hypertrophy, what now happens is that the main thing, remember, the prostate is sitting just below the urinary bladder. And the urethra, which is the tube that gets urine out of the bladder, comes from the bladder, and the prostate encases this tube as it goes down. When this prostate enlarges, it puts pressure on this tube. So that reduces the effort in getting out urine, or the urine flow. So what are the symptoms? So you will guess the symptoms will be some obstruction to the urine flow. And this obstruction could be structural, which is what we call obstructive, or it could be dynamic. So in terms of the structural one, which is the prostate itself being a mass of tissue that is preventing or constricting this tiny tube from getting the urine out. So things like nocturia, so you're going frequently at night to pass urine. Frequency, you're going so many times during the daytime to pass urine. You know, you're in a meeting, you can't stay 2-3 hours, you're going to pass urine, you're coming back, you're going and coming back. And then urgency. So urgency means you want to pass urine, but you can't wait. You have to go immediately. We have a common joke that they say, if somebody calls the urology clinic, the urology clinic is the clinic that where you have the doctors that look at your prostates and the urinary issues. So they usually joke that if you call the urology clinic and the lady at the receptionist asks you, can you hold? That means, can you wait? And if you say, I can't hold, then the receptionist will say, oh, then you have to come immediately. But this is only a joke, meaning that you cannot hold is the phone, but they means if you cannot hold your urine, then that means it's an urgent thing. You have to start coming to the clinic. So these are the obstructive symptoms, 3 of them. Then you have other 4 symptoms which come as a result of the dynamic obstruction. So this dynamic obstruction could now give things like the hesitancy. All right, so you go to urinate, you get to the bathroom, and you want to urinate, and there's a delay. You can't start urinating. That's what we call hesitancy. You have intermittency. Then, you urinate, it doesn't finish, you urinate again. And then you can have incomplete emptying. So you go to the restroom, you urinate, you come back to your seat, and you have to go back again 5-10 minutes or 20 minutes later. So you're emptying, but you're not emptying completely. And then the last one is the weak flow. So you go to urinate and you're urinating and it's coming like a dribble. These 7 symptoms are what we call the prostate symptom index. The Urological Association look at these 7 symptoms closely when you come to complain of difficulty voiding. So in a nutshell, the symptoms that you can get as a result of BPH will be one of these 7 symptom complex that I mentioned: nocturia, frequency, urgency, which are the obstructive symptoms, or the dynamic symptoms, which could be hesitancy, intermittency, weak flow, or incomplete emptying. These 7 symptoms, we look at them very closely. Then there are a group of people who have urethral symptoms or problems voiding, which is not related to this. People have coined so many terms to describe it. Some say it's functional, it's structural or functional, or it's intermittent. But all put to play, what we still look at are these 7 symptoms. Mainly, the doctor will ask you these questions to determine what's the extent of the obstruction you're having and what could be done.
Wow, this was an extensive explanation and insight about the BPH. Doc, what are the effects of BPH? How do you diagnose it?
Diagnosing BPH. Okay, so diagnosing BPH, as everything is, one is a history. You come to the hospital, the doctor asks you questions, like I said, revolving around this 7 symptom complex. How many times you go to pass urine, can you hold it, can you not hold it, do you have to go immediately? When you go, do you have to go back after a few minutes? These things help us determine the extent of the problem you're having. Then the next one will be the diagnostic tests we do. Again, the digital rectal exam is one thing we do, which is the doctor uses the gloved finger, puts in your anus, your anal passage, and then try to palpate the prostate. In BPH, as against in prostate cancer, in BPH, we are looking for enlargement of this gland. So enlargement of this gland could be in the peripheral lobes. It could be in what we call the median lobe. The median lobe is the part of the prostate that is very adjacent or very close, in close contact with the urethra, which is passing through from the bladder. So this is where it enlarges and it can push into the urethra and cause the obstruction. So we check these things. We try to make an estimate of the volume of the prostate. And then the other thing is we do ultrasound to check quantitatively what is the volume of this prostate. Then if it's not clear, we can do CT scan, we can do MRI as well. So these will be the things we use to diagnose it. And usually if the volume is large and you're having these obstructive symptoms, we normally say that you have BPH.
Wow. Doc, in problems of life, one thing is to have problem, another thing is to find a solution to your problem. Having said this, do we have hope of treatment? Is there treatment for this BPH or is it terminal?
Oh yeah, there are treatments. So interestingly, BPH is one of the disease conditions that there are proven treatments, many of them. So there is hope for every man. So one thing I forgot to mention is that in terms of the symptoms, some people go to the extent that they notice hematuria, which is blood in the urine. Blood in the urine could occur sometimes because somebody goes to urinate, they are straining. And when they are straining, some of the capillaries, which are the tiny blood vessels in the prostate area, could burst open and you could see blood in the urine. I know this is very frightening. I can tell you my own personal experience. When I was in the medical school, I got a distress phone call from my mom. I think I was in the 5th year, and she told me, that my dad went to urinate and he saw blood, and immediately he came out. The man was so frightened. He started telling my mom where some documents are in case something happens, and my mom got so terrified. She called me and said, listen, your dad is telling me things he never told me. Decades have been with him. Something bad is happening. You have to come home. So I rushed home, and I went there. I saw he was having hematuria. I took him to the hospital. That was how we diagnosed his BPH. Just for you to know that the symptom, apart from the 7 symptom complex I mentioned, which hematuria is not one of them, hematuria could be the symptom. My own personal experience, that's how I diagnosed my dad to have BPH. So in terms of treatment, there are many treatments. So treatments move from non-pharmacologic to pharmacologic treatments. So non-pharmacologic treatments will be, like I said, diet and activity modification. You know that BPH, you're going to urinate frequently. So you have to pick your poison. If you have an event you're going to, that's not the time to drink lots of water because you'll be voiding all day. So you try to limit the volume of water or any liquid that you're taking when you're going for an event within which you don't want to be going to void so many times. That's one. The other one would now be in terms of the other treatments that we have, which most of them are medical treatments. So remember when I mentioned the prostate, I said the prostate has the epithelial area, which is the glandular part, and the muscular part. So treatment, we target either of these two. Most times we target the muscle part because remember I told you the muscle part constitutes about 70% of this gland. So we give medications that will reduce the mass of this muscle area. These medications are the alpha blockers. So most of you will remember things like what we call the Flomax here in the US or tamsulosin. It's an alpha blocker which we give, and the aim is to reduce the size of this muscular area. There are other medications that are also alpha blockers. We have alfuzosin, doxazocin, terazosin. They all come in the same. So these are all medications, they target this area. Then we have medications that target the glandular part, which we call the 5-alpha reductase inhibitors. So medication like this is what we call the finasteride. So some people may be on this. Normally when your doctor gives you one and you're still having the symptom, they tend to give you the other one. But the other one, the 5-alpha reductase inhibitors, before your doctor gives you this, they normally check what your PSA is. So please, if your doctor is giving you finasteride, please be sure that your PSA was checked, because what happens is that if you for any reason have risk of cancer and they give you finasteride, it might increase that risk. So these are the medications that we use, the two groups of medications that we use for the treatment, one targeting the glandular aspect, one targeting the muscular aspect, and then we have the non-pharmacologic treatment, which is just modifying your diet, modifying your activity, modifying when you take fluid.
Wow, Doc. For the general public, what would be your advice to them?
My advice to them is this, like I said, one is regular check, especially you're a man above 50 years of age. Talk to your doctor. You're African American, that's a risk factor for BPH. Talk to your doctor about checking for BPH. It's usual rectal exam, digital rectal exam to palpate your prostate. That's where it normally will start. And then if your doctor finds anything of concern, they can do other tests. Like I said, the ultrasound to quantify the volume of the prostate. And of course, if he feels anything irregular in your prostate, then they can go along to do other tests to rule out cancer, like doing the PSA. That's one thing. The other thing is if you notice any of the symptoms, remember the 7 symptoms I mentioned, if you're having any of this, please speak to your doctor. It could be that you're having an infection. It could be just your prostate enlarging. It could be any of this. But like I said, there are proven treatments for BPH, so do not wallow in silence or in ignorance. So it could be checked. Now, the other thing is if you, from a family where people you have your older relatives, they'll say the grandpa had this thing, grandpa was always going to pee whenever we come here. That means he has something like that. So that heightens your suspicion and also the rapidity at which you have to check yourself for these things, because these are the disease conditions that, they are familiar. We're not saying you must have it, but if a family member has it, there's increased risk that you may have it. The other things will be if you have any significant abdominal problem, you have cancer, you have any growth or anything that increases the pressure in your abdomen, then there's risk of having problems in the lower urinary tract. And if you have it, that puts pressure on your prostate. That means you're straining when you're voiding. So that could be another risk. So that also would make you seek medical attention.
Viewers, like I said, when we started, I called him Professor Someono. He's indeed a professor, a teacher of medicine. And today he has done justice to what he is known for. We encourage you to keep watching Anglican Church of the Holy Spirit through the pew and the pulpit. And don't leave this TV station, ACNN, Anglican Cable Network, Nigeria, Abuja. We also invite you to worship with us anytime you find yourself around New York, you're here in the United States. Especially if you are in the Bronx, you will meet us at 3840 Seaton Avenue. Or you want to know more about us, you could visit us at www.anglicanchurchoftheholyspirit.org. Or our number is on the screen, 929 944 3424. Or email us at anglicanchurchoftheholyspirit@yahoo.com or info@anglicanchurchoftheholyspirit. There are many ways to meet us. You can as well look us up on Facebook at Anglican Church of the Holy Spirit, Instagram, and all the social media. Thank you for listening, and God bless you. Thank you.
Thank you.
Thank you, Doctor.